This is David Thompson from the Quality and Safety Research Group. I'm a doctorally prepared nurse that has worked in quality and safety for a little over a decade now. What I'm going to talk to you about today is conducting a morning briefing. It is one of the Comprehensive Unit Safety Program, or the CUSP tools. And the title is Improving Situational Awareness by Conducting a Morning Briefing. So to start out with a little bit of background, we in medicine are very behind other risk-averse industries such as aviation or nuclear power or offshore drilling. We have taken some of their ideas and moved them to healthcare, and I think very effectively. Situational awareness, which comes a lot from the Department of Defense and especially from aviation and nuclear power, it has to do with preparation, planning, vigilant, distraction avoidance, and workload distribution. So the whole idea behind situational awareness is that members of your team have an understanding of what is going on, so you understand the procedure or the plan for the day, and what is likely going to happen next, so you know how things are going to flow for the day. And that will help you decide how you're going to plan activities, what staff are going to be involved, and maybe even that you may need more staff in order to complete everything that you have planned. The team members are all alert to developing situation because, again, they've understand that plan of the day. They've had a briefing with you, so they know the flow for the day. They're sensitive to cues and are aware of their implications, and you'll see that I have a yellow flag. Some people call them red flags or a change. A cue can be anything to indicate caution. It can be a change in patient's blood pressure. It can be a call from the OR telling you that they have a patient that just doesn't happen to be on your list of admissions. So they're anything. You can call them yellow flags as caution or red flags indicating that there's a change that's unplanned. And the whole idea behind situational awareness is to review those cues and be able to handle them effectively and to plan your day better for all involved. So a briefing is what we're going to talk about today. And a briefing is a discussion between two or more people, often the team, using succinct information pertinent to an event. Now, the Department of Defense has been using briefings for a long time. We are just now, there's the World Health Organization has launched a safe surgery campaign in which there will be not only a timeout, but a briefing, a timeout, and a debriefing. So we've been using briefings in the ICU for a while, and a morning briefing is kind of specific to the day, the actual activities for the day. And what the briefing does is it maps out the plan of care, and that's usually decided by the attending physician or whoever's going to be responsible for oversight, and or the charge nurse or the nurse manager, depending on your facility. You identify roles and responsibility for each team member for any planned event that you have, and that enables you to heighten the awareness of the situation that you're working in, or i.e. the day's activities. It allows your team to plan for the unexpected, and team members' needs and expectations are met because instead of not understanding, you can go back around to all the team members that are in your ICU delivering care and explain how their day's going to go, whether their patient is staying, whether their patient will be discharged, if they'll have an admission, those kind of things. And if you assess that they need more help, you can allocate another staff member to come and assist them. So a briefing really is a way to plan for a very, very strong plan that will allow for you to set the tone for the day. Chaotic versus organized and efficient, and we all know we prefer to work in an organized and efficient manner. It encourages participation by all team members. When I say that, that means that anybody participating in the briefing is allowed to speak at any time. They can bring up any questions that they have. It's owned by all team members, so it doesn't mean that the physician will always lead. It does mean sometimes that the nurse will be bringing them information that they were not aware of. The people that are speaking, we do it in a way that we show we're organized in thought regarding the procedure that we're talking about, or if it's a planned admission. It establishes competence. The competence is who has what skills, so that helps you decide what patient's going to go where based on the experience of the nurse delivering care. Who performs what? That may have to do with the resident in training or which physician will be placing the central line. Who knows what? So who's going to be your resource nurse? Who's going to have the information to provide for the resident who's doing a new procedure? And essentially it will allow you to predict what will happen later because all your answers have been completed. You have a good understanding of what's expected. You know what equipment you're going to need. You know what medications and what type of consults are going to be done. So again, effective briefing will set the tone for the day and allow for a much more organized and efficient day to deliver care in. Now, you can conduct a briefing at many different times. As I was talking before, we said prior to any procedure in any setting, situational, where a change in patient status or deviation from a plan of care or reporting off. The beginning of the day is really important, and we've set this as its own tool for a morning briefing to just start the day on the right tone. And the reason it's so important is because you have a whole new group of providers coming in. You have the attending physician who may not have been doing rounds or may not have been alerted to any change during the night. So optimally, you want the physician who's going to be doing the rounds and is responsible for the ICU patients that day. Now, this could be an attending physician. This can be a general physician that is rotating through, whether you use pulmonologist, anesthesiologist, or intensivist. Then we also like to include the charge nurse from the night shift, and if at all possible, it's optimal to include both nurses so that way the physician doesn't have to be the mediator to pass on the information from one nurse to another nurse. And so it can be effectively engaged as part of the morning shift report that the two nurses have, only we're including the physician. The process is simple. Three simple questions. What happened overnight that I need to know about? Where should I begin rounds? And do you anticipate any potential defects in your day? The answers are important and potentially could impact each member of your team and the patients under your care. So an easy way to get started with the most effective patient care delivery you can have. So what happened overnight that I need to know about? You should be thinking about, was there adequate coverage, i.e. physician coverage, nursing coverage? Were there any equipment issues? Did something not function right? Were you missing a piece of equipment? Were new cases posted to the ICU that weren't there when you left the evening before? Unexpected changes in patient acuity? And were there any adverse events? And the goal is to keep each other informed, to be on the same page, to have that situational awareness or the same mental model. So where should I begin rounds is impacted by three trigger questions. Is there a patient who requires my immediate attention secondary to acuity? And we had just asked, was there a change in patient acuity? So this might dictate that the patient with the highest change in acuity, maybe the patient that arrested over the evening or became hypotensive and went into septic shock, might be the first patient that needs to be seen. Which patient do you believe will be transferring out of the unit today? This is significant because you may have an OR schedule that is going to begin sending patients out by 11 a.m. and you don't have an empty bed. So you want to see who can go out, and you want to be able to know the status of how quickly that bed can be available. And if possible, who has discharge orders written? Some teams have been around during the night shift and have already left discharge orders for their patients. That allows you as the charge nurse and the attending physician to decide whether you need to see the person with the highest acuity because they need the medical expertise. If not, it allows you to go to the patient that is most likely to be transferred, and preferably the patient that already has orders written because it will be easier to get them to a patient floor. You might decide to start with the patient who's most ill and proceed based on their acuity. You might also decide that these are equally important. If you have a fellow working with you, you may send the fellow to address the issues of acuity and go to the first patient that may be transferred out that day. The patient with orders always rises up in the hierarchy on who is rounded because If they're stable, they'll be your first patient out the door and they provide you your first open bed. And that allows that nurse to potentially take the next admission. As you continue planning your rounds, you want to ask how many admissions are planned for today, what time is the first admission planned. Both you usually get from your either admission, discharge, and transfer sheet, or if you're a surgical unit, from the OR sheet. How many open beds do we have, and are there any patients that are having problems on the inpatient unit? And that is because you want to be alert to patients that may require an ICU admission. In this way, everybody again is on the same page. You're gaining an understanding of how the day is evolving and what you need to plan for, whom you need to inform of changes in patient assignments, and potential patients that may need an ICU bed that wasn't already planned for. Do you anticipate any potential defects in your day? And a defect can be something as simple as patient scheduling. You might find that a patient is scheduled for an MRI and you need to have a physician go down with the patient. That might change how the physician delivers care that day or what order he sees the patient. Equipment availability and problems often are not uncommon in the ICU. A call to clinical engineering or borrowing equipment if you need to. Outside patient testing and road trips, because again, this requires not only the nurse to go off the floor, but often requires a physician to go off the floor as well. And what's your physician or nurse staff patterns? Have you had any sick calls in? Is the physician keeping up with his assignment? And then provider skill mix. You have a very different day if you come in with one experienced charge nurse and all new grads versus an adequate skill mix of people with many years experience and only a few nurse grads. Defects and problems, glitches to smooth out so that you sail through your day. And then lastly, when you do identify defects or problem, you want to assign a person to that issue. It doesn't have to be the charge nurse, but you want to assign it to somebody that is in the unit, so it is often a nurse, and have them follow up and keep the leaders informed. During the day, that would be your charge nurse. You identify actions taken to meet any specific patient or unit needs. You report back to the staff what was the action that will be taken. And if it's ongoing, say it has to do with a piece of equipment that was malfunctioning and it's in clinical engineering, how long you have a piece of loaner equipment and when they think they'll have, let's say, your defibrillator back to you so that it's functioning and back on your unit. And you keep reporting this off until each one of the problems that you've identified is resolved. And that way everybody, again, is situationally aware and on the same page. This has been very effective. We've used this in many of our collaboratives in both our Michigan study. We've used this with the Robert Wood Johnson Adventist Collaborative and introduced this as a way of getting physicians to work with their providers so that patients did have all of their needs addressed, to identify which patients could have their central lines taken out and which patients should be seen first. Very effective, and we've even found this effective when an intermediate care provider is responsible for patient care, such as a nurse practitioner or PA working with the two charge nurses. Thank you.